points where we can ask questions, that would be really helpful.
Sorry.
Can I get the next slide, please? Okay. So this is our agenda for the day. We're going to go through our welcome, who we are. We'll go through the overview of Medicaid managed care, the expansion goals, and procurement. We will also do some updates and discussions with key opportunities for policy and operation changes in 2026 contract. This will include service areas, transportation, prescription drugs, rural access, provider workforce, and telehealth. We will then open it up to general public comments, and then if no one else has anything to speak about, we will be done for the day. Next slide, please. All right, so we have our Chief of Managed Care Quality and Assurance, Jamie Evans. She will be speaking to you about all things managed care, along with Patricia Beck-Weaver. She is our Social Services Program Specialist 3 for Managed Care and Quality Assurance. And then again, my name is Melissa Knight, and we all work to bring out and roll out statewide. And then I'm not sure if Teresa Carlston, our Deputy Administrator, or Stacy Weeks, our Administrator, are present, but they also do oversee statewide managed care. So we're happy if they are here. For today, we are hoping for a really interactive session with everyone. And we invite your questions throughout this workshop. There are two ways for you to engage, ask questions, provide additional input, which is verbal participation and written participation. We will pause in a few places during today's session to take questions and comments verbally. For people logged into the Teams platform, you can get into line and ask questions by using the raise your hand feature in Teams. If you've joined via phone, press number 5 on your phone to enter the line and to ask your questions. When we come to the comments portion of this session, we will read out names or phone numbers in the order of the line, and we will bring people off mute to ask their questions. If you can unmute yourself, that is also acceptable. I would like to note that we have a lot of participants in today's session. We will do our best to answer all of the questions that we get, but acknowledge that that may not be possible. We will provide contact information at the end of today's session to have questions submitted to us if they're not addressed at the end of the webinar. And with all of that good information, I will now turn it over to Jamie.
Thanks, Melissa. Next slide, please. So I'm going to give you the next few slides, just an overview of Medicaid managed care, our expansion goals, and procurement. Some of this will be review from the last public workshop, but good information nonetheless. Next slide, please. So just understanding Nevada's Medicaid delivery system. We have two delivery systems. We have fee-for-service and managed care. Fee-for-service is a system where the state sets the rates and pays providers directly per service. Challenges that we have with that system is that it rewards volume only. It's a risk to the state budget, and there's little to no utilization management. It is the members that are covered under fee-for-service are waiver recipients in all counties, are aged, blind, and disabled members in all counties, and currently all members in the rural counties, which as of October 2023 comprised about 28% of our Medicaid population. The managed care system is a system where the state contracts with managed care organizations, or MCOs, to manage the cost, manage utilization, and improve quality of care. MCOs develop provider networks, and they pay their providers negotiated rates that they have negotiated with each of their providers and provider groups. Currently, Urban, Clark, and Washoe counties are covered by managed care, and the populations include children, parents, and adults without children. And we do have voluntary enrollment in managed care for American Indian, Alaska Native, Members, children with special health care needs receiving Title V services, and children that have severe emotional disturbance determinations. And again, as of October 2023, that comprised about 72% of our Medicaid members. Next slide, please. The role of managed care organizations is for our Medicaid members is maintaining an adequate network of healthcare providers, providing care coordination, patient education, preventive care, ensuring the right service is provided at the right time, and providing value-added benefits, which are additional services that are offered by MCOs outside of their capitation and at no cost to the members. And these are services that are not covered by fee-for-service. Some of the services that are provided by Medicaid are carved out of managed care. Those MCO members still have access to the services, but they're paid for and authorized through fee-for-service instead of the MCOs. Those examples currently include non-emergency medical transportation, home and community-based waivers, targeted case management, and there's a full list of those carved out services in the appendix. And just for awareness, MCOs must ensure their members receive the same amount, frequency, and duration and scope of services as provided to recipients under fee-for-service. Next slide, please. Every 4 to 5 years, Nevada undergoes a procurement process to select MCOs for its Medicaid population. The following four, the following 4 health plans are the ones that we've had since January 1 of 2022, which was our last contract, the start of our last contract cycle. So we have Anthem Blue Cross Blue Shield, Molina Healthcare of Nevada, Silver Summit Health Plan, and United Healthcare Health Plan of Nevada. And Nevada, as you know, is launching a new procurement process for our Medicaid MCOs, and the new contract will begin January 1, 2026 in alignment with our expansion to statewide managed care. Next slide, please. Speaking of the managed care expansion, the 82nd legislature authorized the funding of expansion to Medicaid managed care to cover most populations in all counties in Nevada. Again, starting January 1, 2026, an estimated 75,000 individuals, including children, parents, and adults without children, will be added to managed care. These are folks that are living out in the rural areas. The remaining approximately 126,000 individuals in fee-for-service Medicaid currently will remain in fee-for-service, and that includes Katie Beckett, children in the welfare system, individuals with disabilities, seniors age 65 and over, those on Medicare, and people receiving home and community-based waiver services. Next slide, please. To date, we have been doing several activities to gather valuable input from the community and from providers. We have done rural outreach and have met with 13 rural hospitals. We did that last fall. We will continue to meet with rural hospital systems and other key rural stakeholders to better understand healthcare challenges facing rural communities. We did a request for information in July of last year, and all of those stakeholders and members of the public were invited to submit responses. That information is posted on our statewide managed care webpage. We'll have, I believe, a link to that later in the slides. We've also conducted a public workshop on February 22nd that many of you may have attended. We also have that recording and the slides from that meeting, as well as a summary of the key takeaways from that meeting, also posted on our statewide managed care webpage. And we can definitely put that link to that webpage in the chat for those that are able to see that. Next slide, please. Moving into the meat of this public workshop to talk about the updates and key opportunities for policy and operation changes in the next contract. Next slide, please. Some of the areas for potential policy and operation refinement include updates that would optimize Medicaid for Nevada residents and enable expansion to rural areas. The key policy areas include provider network, behavioral health, maternal and child health, social determinants of health, community reinvestments, value-based payment design, market and network stability. But the focus of today's session, we'll do a deep dive on a few of these topics, including the service areas, transportation, preferred drug list, rural access, provider workforce, and telehealth. Next slide, please. DHCFP has decided there will be 2 Medicaid managed care service areas under the new contract. We will have an urban service area that includes Washoe and Clark County, a rural service area. Interested plans will be required to bid on both service areas. DHCFP anticipates selecting a maximum of 4 plans. All selected MCOs would serve the urban service area. 2 of the MCOs would also serve the rural service area. DHCFP will determine the final number of MCOs based on final bidder scores, balancing member choice, provider networks, and MCO operations. This approach was informed by stakeholder feedback about the balance between ensuring member choice, minimizing administrative complexity for providers, and meeting the distinct needs of the urban and rural areas.
Okay, so we're going to ask a few questions that you can answer in the chat. What are the key factors that DHCF might consider in determining the final number of MCOs serving urban and rural areas? And how can DHCF ensure a smooth transition for members in the event of a managed care change entering or exiting starting in 2026?
And Patty, do you want both comments in the chat and folks to raise their hand, or just the chat?
Do you want to ask these questions now, Jamie, or do you want to wait until we're done with the presentation, or just put their questions in the chat now?
Folks can put questions in the chat. I think the intent is to facilitate just a few minutes of discussion here. So if anyone has any feedback or questions, they can raise their hand or put the question in the chat. I do see that we do have one question in the chat from Cindy Smith. In regard to page 9, fee-for-service covered individuals. Will individuals having Medicaid secondary to a non-Medicare primary plan be covered by the MCOs or fee-for-service? And Cindy, I'm not 100% sure that I understand that, but I think what you're saying is if someone has other primary health insurance besides Medicare, whether they would be in fee-for-service or managed care, is that correct?
Exactly, yes, ma'am.
They could be if they're part of the population that is identified on that slide as far as children and adults without children. If they have primary health insurance that's not Medicare and they're not one of the populations carved out of managed care, yes, they would be in managed care, and their other health insurance would be their primary insurance and Medicaid would be secondary.
Okay, thank you.
Okay, next slide.
And I think we have one additional question in the chat, kind of a continuing of the thread around the eligibility for managed care. We have a question about whether foster youth, the foster care population will be excluded from managed care. And I will just go ahead and read Teresa's response, which is currently foster care is not an A category enrolled in managed care.
So moving on to the topic of transportation, currently non-emergency medical transportation, or NEMT, is available to fee-for-service and managed care members through one transportation broker, which is MTM. DHCFP is considering including NEMT as an MCO responsibility in the Medicaid managed care contract, meaning MCOs must ensure their members access to NEMT either directly or through the MCO's own contract with a transportation broker. In examining this policy question, DHCFP is considering input provided by stakeholders about transportation challenges for members, especially those living in the rural regions of the state.
Okay, so we have a few more questions that we want to pose for the group. What are the key opportunities for managed care to improve access to non-emergency medical transportation? And what key managed care contract requirements related to non-emergency managed care transportation might DHCFP consider to help address access needs, especially in the rural area? And we'll wait and take some questions.
There is a question in the chat. Will the MCOs be required to enroll state-run providers that are considered safety?
I believe that currently our current contract does indicate that the MCOs are to contract with essential community providers. So are you asking about specifically essential community providers? Yes, they must negotiate in good faith with
So
Oh, thanks,
Tammy is
Tammy.
with our DPBH partners over at Community Rural Health Clinics. And so Tammy, you can hit me up offline and we can talk about that, because they are instructed to negotiate in good faith with providers. And from what I understand, they've attempted to do that with our list of ECP providers, except for those that have refused to contract with them. So we can't require partners to contract with the MCOs, but we can ask the MCOs to make a good faith effort to contract with those providers. So if you want to talk about that offline, you can contact me.
Thank you, Teresa.
Any other questions? Oh, I see in the chat. Sharon says MTM often is short of drivers or has no drivers in the rural areas. A challenge would be ensuring there are sufficient drivers for rural area transportation brokers. And we are working on that. And I think that I can let Jamie or Teresa maybe elaborate a little bit more on some of the areas we're looking at regarding non-emergency medical transportation.
I think that we're in agreement that MTM is often short of drivers, and it is something that we are taking into consideration as we're working on potential contract and policy language for moving NEMT under managed care responsibility.
And I think just to clarify, in addition to that, right, like I think people are historically familiar with MTM being our NEMT broker. This change would allow the MCOs to either partner with MTM or to create other options in those rural communities where it may be more difficult to get MTM drivers in those rural areas. So it's just allowing them to be a little bit more creative and operate outside of that one broker kind of service.
Thank you, Jamie and Teresa. And then James has another question to follow up on the foster care population. While this aid category is not currently enrolled in managed care, does DHCFP intend to make this population eligible for managed care beginning with the 2026 contract year, or sometime thereafter?
This is Teresa. It's not our intention to make this aid category eligible under managed care effective 2026. And beyond that, I think we're working towards a children's behavioral health transformation project, and all of those intricate details have not been outlined yet. And so I'm not aware that we have a specific date to or permission to move other populations into managed care post 2026. But there will be language in this contract similar to the language that's in the current contract that says Nevada retains the right to move other eligible populations into the contract. That's what it currently says now. In the last two contracts that said that, and we haven't moved additional populations into the contract. So it will retain that language should it be deemed by state law or budget authority to add populations. But at this time, there's not a specific plan laid out for that.
Okay, we have another question. Home-based care and telehealth options seem to complement the non-emergency medical transportation access model. There is an opportunity to introduce some level of triage evaluation process to better discern other ways to provide care, since non-emergency medical transportation is sparse and costly in the rural region.
That is good feedback. Thank you.
Okay, I think we
I
can go
think
to
we
the
can move on to the next slide. Yeah. Okay. So prescription drugs, DHCFP is considering standardizing the preferred drug list across fee-for-service and all MCOs. For background, a preferred drug list establishes the outpatient drugs that Medicaid encourages providers to prescribe based on clinical criteria. And having more standardization would help streamline member experience across MCOs and reduce administrative complexity for providers working with multiple MCOs.
Okay, and again, we'd like to hear from you about this issue. So either raise your hand or provide a verbal comment or put your comment in the chat. So what would be a key advantage with transitioning to a single or a line prior authorization across fee-for-service and managed care? And then secondly, what potential challenges would you see with this shift? And we'll wait for some responses.
I'm not seeing any questions in the chat or hands raised. So I think we can move on to slide 16.
Somebody just raised their hand.
Oh, thanks, Laura.
Hi, as the PAR system is going to continue for medications, because I thought the last legislative session, some bills were passed that if a prescriber prescribed a medication, the health plans were not going to be able to say no to it, what the prescriber is recommending. So is that the case, or what are you referring to as preferred drug list is going to be a recommended list, but the other drugs will still be approved without a PAR.
Yeah, so Mr. Barbosa, this is a little bit different than the prior authorization form. I think the legislation that you're talking about was specific to a set or class of drugs. I'm not a pharmacist, so don't quote me on that. You probably know what that is better than me, but it was like specific to HIV drugs and a couple others, right? Well, it did not go across all drugs and covered pharmaceuticals for Nevada Medicaid. So in Medicaid, we are required to have a pharmacy benefits manager, which operates our fee-for-service delivery program, right? And then in addition to that, each MCO has their own pharmacy benefits manager. And so right now, they each have their own contracts and operate based off of their preferred drugs. I think what this single PDL would be that they would be required to have the same preferred drug list that the state fee-for-service pharmacy benefit manager operates. Any prior authorizations that are outlined in policy for Medicaid or by the MCOs would still be under their utilization management requirements. So this would not be specific to prior authorization. This would be mainly like what would be the benefit to align a preferred drug list to the one that the state operates. And I think one of the things we've heard from other members is that when they transfer back and forth between different health plans, they would not have to change different preferred drugs. And so that's like one of the benefits that we talked about as we were putting this together is are there other benefits to doing this?
Okay, thank you.
I think we can go on to the next slide, please. Policy update around rural access. DHCFP is considering a requirement for MCOs to develop, implement, and maintain an access improvement plan. These plans would include workforce development and infrastructure telehealth investments in regions with the most limited access to healthcare services. The MCOs would facilitate access stakeholder collaboratives that would inform the plans.
Okay, and again, we invite you to put your questions in the chat. What elements of workforce training, investments, and telehealth equipment should DHCFP consider incorporating in the Access Improvement Plan? And secondly, what are the key opportunities to increase access and meet members where they are in rural areas?
Abby, I wanted to make sure that you saw the comment from Sarah Adler in the chat.
Yes, Sarah, and that's a good question that you said too. And we can actually send you, we have a statewide managed care website where you can send questions for follow-up, and I can put that in the chat if you'd like. And Juliet's going to put that in there. Okay, and then we have another question. Since the rural areas, and this is from Jason Yates, since the rural areas are already limited on providers, even with telehealth, hopefully the MCOs will not be allowed to capitate provider types, further limiting access to care.
I think, Jamie, that speaks to our network adequacy standards that we will set as a state, right? And then anything that is outlined by the state, if they meet that network standard, then they as a health plan and within their model would be able to close their network if it's determined that there is access. But We haven't finalized what those will be for the rural areas. And I think we are all in agreement that the rural areas are extremely limited on providers, which is why setting an access standard is proving to be a little challenging at this time. But we hear you, and it is something that's on our radar that we're working through and trying to finalize before we post for procurement.
And then there's a follow-up comment from Sharon. Some rural areas do not have good internet service. Would a representative be able to go to the rural areas to help members navigate their plan?
I think
some of.
Go ahead, Jamie.
I was just gonna say that this is good feedback. This is the information that we're looking for consideration as we're working through the contract language. Did you have something more to add to that?
Oh, I was
Teresa?
just gonna say, in some of our visits with the rural hospitals, with the rural hospital tour that we did, we talked to some of the specific counties that had that issue and talked to them about the need for broadband in their area and possible MCOs paying for some infrastructure to set up telehealth related services. And so I think this just adds to that feedback that we got. And it is one of the things that we have flagged to try to work through with this procurement.
Thank you, Teresa. And Dominic has another question. The elements listed are all good. I suggest considering community member education, engagement elements as well. Many in rural regions need to be retrained to engage in routine care, especially once availability increases.
Agreed. That's good feedback. I'm not seeing any additional hands or questions. So next slide, please. Provider workforce, DHCFP is considering a range of policy and operational requirements to reduce barriers for providers to participate in Medicaid managed care. This is based on feedback that we received about the major challenges that influence provider decisions to participate or continue participating in managed care. We'd like to specifically talk about two potential policy changes that we're considering. DHCFP is exploring standardizing prior authorization policies to minimize burden for providers. And we expect to include new or strengthened requirements for MCOs to provide billing and claims training and technical assistance for providers.
Okay, so again, we'd like to hear from you either by raising your hand or provide a verbal comment or in the chat. So some of the key considerations, the pros and cons for aligning prior authorization policies between fee-for-service Medicaid and managed care Medicaid. And secondly, what types of training would be most effective in supporting providers with navigating billing claims requirements for managed care? Looks like we do have some questions from JC Flowers. Maybe consider a dedicated space for patients to go within their communities. Oh, this is for telehealth, and which is somewhat related to workforce, I guess, for private telehealth visits. And then Patrick said stipends could be given to people seeking to obtain healthcare certifications, like community health workers. I think that's what you mean, Patrick. Is that what you mean, Patrick? Yeah, and CNAs. Okay, good points. And then Dr. Evans says, agreed with the standard prior authorization form. There's really no downside to that in any way. Thank you. Again, we got thumbs up on having a standard prior authorization form. Okay, and then we have another comment, providing technology that will integrate the prior authorization and claims processing into their EMR.
That's a good point as well.
I like that when it says, let's make it easy. And then again, aligning a prior authorization process would be amazing. And being able to check in online instead of calling and emailing or getting fax approvals for MCOs, it's very frustrating. And then another comment is workforce development could go hand in hand with localized telehealth, teaching MAs or community health workers to present to patients.
This is great. I'm loving that we're getting so much feedback in the chat. This is awesome. All right, I think we'll go ahead and move on to the next slide. Oh, Christopher's got another comment. I don't
Okay,
know how you, oh, go ahead, Patty.
I don't know how you would measure it, but the MCOs need to have strong provider portals for easy authorization if they can't do EMR integration. And then also CYLs are differently interpreted by the MCOs from fee-for-service and our Chapter 400 for mental health. Okay, we spoke too soon. There's a lot of comments coming in. Also, CYLs are differently interpreted by the MCOs. Develop short videos that billing clerks could maybe watch and learn the process for filing a claim. And then limit calendar year limits. The date range and the authorization requirements are currently different for each MCO compared to fee-for-service.
Okay. Every time I say we can move on to the next slide, someone makes a comment. So just give it just another second just to see if we have any other comments. Biggest benefit to all providers would be one process. Yes. Recently, one MCO PAR required a letter from a parent to support services. It's just so random. And again, we will have an email address where everyone can provide additional feedback that we'll have later on in the slides. Yes, and if you could send that information, Diana, to Teresa about the letter from the parent. All right, we'll go ahead and move on to the next slide. Telehealth. DHCFP is exploring policy updates to encourage the use of telehealth in a way that supplements but does not replace in-person care. We'd like to specifically talk about two potential policy changes that we are considering. In the RFI, stakeholders recommended that the state provide coverage for interprofessional consultation and managed care. So we are exploring the adoption of that addition. And we also heard from stakeholders recommending coverage for remote patient monitoring that would allow off-site providers to track member health.
Okay, again, we invite you to raise your hand or speak verbally in the chat or write a note. So what are the key considerations for covering interprofessional consults through managed care? And what specific uses of remote patient monitoring could help improve care for members in rural areas? So we'll wait a few minutes for some responses. Okay, we do have a response from Dr. Evans. We have already rolled out remote patient monitoring to our exchange members in the rural areas. We use blood pressure, pulse, oxygen, weight, and glucose with constant triage and feedback. Great. And then we have another response. If the state licensure allows for telehealth, then the Medicaid and the MCO should allow it too.
This is Teresa. I think I need more information about that, Jason, because I'm not quite sure what you mean by that. So can you clarify for me? Because the state licensures allow you guys to do a lot of things within your scope of practice that may or may not be covered as a benefit under Medicaid. Is that what you meant? Okay, thank you.
Okay. Thank you, Teresa. And we have another question or another comment. Allowing providers to work as a team and support members would increase patient outcomes. Tracking generalization of skills into their daily lives through remote monitoring would also increase outcomes. And then another comment about travel. Reducing extensive travel between providers would help those in extreme rural areas. Patients also need to be trained on using telehealth technology. If telehealth will be used by the MCOs to support rural members, the network adequacy provisions need to account for providers outside time and distance standards to count for those members. That's from Joy.
Yes, Jamie, does our current, I think we just this last year, and I know it's not specific to rural areas yet, but just this last year, didn't we incorporate reporting metrics around telehealth in our in our network adequacy report?
I think that we discussed with HSAG about considering it, but we don't have specific requirements outlined for telehealth.
Okay, I thought we were reported on, I maybe not have specific standards, but I thought we were reported on telehealth utilization. That's a good note, though. Thank
Yeah.
you.
Do we have any other comments related to telehealth policy updates?
Looks like you might be safe. Oh, okay. As soon as you said it, here they come. All right. From Providence, key considerations: patient access to devices, charge for private space for e-consults. That's regarding telehealth.
Yeah, and I think chargers, meaning chargers for the devices. Is that what you mean, Rebecca? Okay. All good points, for sure. All right, I think we'll go ahead and move on to the next slide. I think we are up to general public comment. And I will pass it over to Melissa.
Thank you, Jamie. Can I get the next slide, please? So again, we would like to reiterate that there are two ways for you to engage during this public comment, to ask your questions and provide additional input. We do encourage verbal participation and written participation. For those that have logged into the Teams platform, please get in line and by using the raise your hand function. For those who joined via phone, please press 5 to enter the line to ask your question. Additionally, you will be able to use the chat to ask questions and share comments like we have been doing through the meeting. But again, please feel free to ask your questions by using the raise hand function.
Yes, JC is asking if the RFP is still expected to drop in September, October. Our plan is October 2024.
And I've got my eye on the list of participants here, and it looks like Patrick Kelly has raised his hand and is first in line. So Patrick, if you'd like to unmute yourself and ask your question, please feel free to do so.
Thank you. My name is Patrick Kelly with the Nevada Hospital Association. During our earlier comments that we submitted, we talked about the administrative burden that rural hospitals and other rural providers would experience. And I just want to thank you. I've seen several examples here today where you're trying to address that issue, and I appreciate it and just hope that you will continue working in that regard. Thank you.
Thank you, Patrick. That is definitely our goal, to make sure that we are addressing those issues that we've heard.
There's
So,
a question. Oh, go ahead, Jamie. I'm sorry.
Sorry, I was just I see, Christopher, your question. What weight are you giving to MCOs that have clinically integrated networks, better care outcomes versus MCOs who don't? Are you asking weight as far as the evaluation for the RFP bidding process?
Yes, that's correct.
Okay. I don't know that we have fully outlined the requirements for the bidding process or the evaluation process just yet.
And it looks like we have a hand raised in the line. We have Esther Quilisi. If you could take yourself off mute at this time and ask your question, that would be great.
Hi, good afternoon. My name is Esther Quilisi, CEO of Vitality Unlimited. We operate treatment centers and certified community behavioral health centers in Northern Nevada. We have dealt with all the MCOs and fee-for-service. Fee-for-service is amazingly efficient at processing claims. You submit your claim, bona fide claim, and it's paid within the following week by the end of the week. What we would like to see is the MCO payment as efficient as fee-for-service. It just seems like there are, and one other thing too, we have liaisons within fee-for-service that we can contact that are responsive. We would like to see that MCOs can match that they are efficient in payment and that they are efficient in the liaisons getting back to us as providers. Do you have any comments about how you can make that implicit in the agreements that you sign with any of the MCOs? Did anybody hear me?
Esther, this is Teresa.
Yeah.
I just want to do some reflective listening because I want to make sure that I understood you. Is your request that we have language that requires the MCOs to process claims the exact same way that DHCFP does?
Okay, Teresa, who's the oh, you mean the fee-for-service organization?
Yes, that would be that would be us, Medicaid, fee for service.
Okay, so Teresa, I don't know what prompts you and your crew to be so efficient and effective, because you are. So if whatever language drives your system, yes, I would hope that you can embed that in the new contract agreements for the MCOs to drive the future system.
So we will discuss with Manatt possible ways to clarify required coverage and claims processing. Unfortunately, MCOs are required or are allowed to have their own utilization management, and that's claims processing. So we will discuss that with our vendor to see if there is ways we can strengthen that. I'm just a little concerned that we wouldn't be able to direct it in that manner, but we'll take that feedback and see if there are other ways we can clarify that.
Well, thank you.
I do see a couple of additional questions or comments in the chat. Cindy Smith said, in regard to the credentialing of interns, will the MCOs align themselves better with Medicaid standards for those interns that meet Chapter 400 requirements for enrollment? And Teresa did a follow-up saying that we have identified that we need to build language around expectations related to interns in the MCO networks. And we do have some additional comments about delays in processing payments or an unspoken burden on providers. So thank you for that feedback. And as Teresa said, we will take that information back to Manatt for further discussion.
I'm not seeing any other hands raised at this time. We'll just remind folks that if you have a question or a comment or an observation, and you'd like to raise your hand to get in line to kind of articulate that out loud, you can use the raise hand feature in Teams. Or if you have joined us by phone today, you can dial *5 on your dial pad, and that will put you in line. We will call on you or your phone number, depending on how you've joined us today.
I'll go ahead and read the comment that's in the chat. And it's from Nevada. I think this is SBDC, Small Business Development Center. They request to be considered for trainings to aid healthcare businesses and DHCFP in implementation and compliance. Healthcare businesses are presently seeking our assistance in various processes and wish to continue receiving our support. We aim to continue updating our knowledge and assisting this community effectively. Okay, and I'll read the other comment in the chat from Diana. In another meeting, there was mention of streamlined credentialing for MCOs and fee for service. It's taking up to 90 days after a provider is approved by fee-for-service to be credentialed with some MCOs. Any other updates on this?
So Diana, yes, we are in the process of doing centralized credentialing. Meetings have just recently started with the vendor that was awarded the contract to do that project. I do not have any additional updates for you at this time, but our provider enrollment team is leading that project.
Okay, and there's another comment. Currently, the Medicaid MCOs are capitated in Clark County for OT and PT therapy for HPN all ages, Silver Summit all ages, and Anthem all patients over the age of 18. So therapy providers cannot even be in network for these plans without being able to join these MCOs. New providers do not want to move to Nevada, limiting access even more. Okay, thank you for that. And then another comment is, will the contract evaluation process measure the MCO's capacity to provide essential benchmark services per the ACA?
The
I think the MCOs are required to provide the services that we outline in the contract as delegating to them. So we wouldn't be benchmarking them to another plan. We would be deciding what Medicaid eligible benefits they would be responsible for.
Okay, we have another question. Are there other states that have recently expanded MCO coverage from urban to statewide? Has the Nevada team been in touch with other states in a similar position? Any lessons learned there?
So we have contracted with Manatt Health Strategies that you've heard on the phone with us today to provide feedback and lessons learned from other states that they may or have communicated with. Teresa, I don't think we've had specific meetings with other states that have expanded to MCO from urban to statewide, but Manatt is doing a fantastic job of providing us information that they have from their experts.
That's correct, Jamie. Thank you.
Not seeing any additional hands raised or comments in the chat. Other than that, Teresa did provide Cynthia Leach's contact information, the agency manager regarding that's overseeing the project for the centralized credentialing. That was in response to Diana Saunders' question. So not seeing any other hands raised. Oh, Cindy just raised her hand.
I just have a question going back to the non-emergency medical transportation. Currently, MTM allows to, for a member to have a calendar of their appointments and get a slight reimbursement. Will that be something that will be considered by the MCOs also when we look at these new providers for transport? Sometimes just having that little bit extra money for the gas, they can drive themselves, but that does help them.
Yeah, I think mileage reimbursement is one of the ways that is outlined under non-emergency medical transportation. And so we haven't hammered out all of those specifics under that, and if we include it under managed care, but I think that's excellent feedback that you would support that remain reimbursable if it was moved under managed care.
Absolutely, thank you.
Mhm.
Okay, I'm gonna say it again. I think that we are done with general public comment because I'm not seeing any additional hands or comments in the chat. So I think we can move on to the next slide. So our next steps right now is that this is our last planned public workshop that we are intending to host related to the expansion and procurement. Stakeholders are welcome to email additional feedback and comments until May 31st. Feel free to the questions that were outlined in today's slide and any questions that were outlined in the slides from February 22nd. If you would like to provide feedback or additional, if you have questions or concerns, please send us that information via email, and we will continue to share materials related to statewide managed care expansion and procurement in additional upcoming stakeholder forums and workshops. And we are still on track to release the RFP in October of this year. Next slide, please. And this is the email address that you can send any questions, concerns, feedback to. Again, we are accepting feedback until May 31st. We really appreciate everyone's interest and time and insights during today's call. If you have any questions, please send those to this email. And thank you so much for attending this workshop.
Thank you.
Thank you.
Thank you.
Thank you.